Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the Deep Dive. Today we're taking a really critical look at a surgical protocol. It's one that fundamentally aims to boost patient safety in gallbladder surgery.
That's right. We're talking about the critical view of safety, or CVS.
Exactly. And this deep dive, focusing on standardization and, the procedural rules, is brought to you by the Surgical Edge podcast.
And we are diving deep today into the definitive protocol. It's the one defined by Strasbourg, backed up by major European guidelines too. But critically, we have to start with the standard disclaimer. This content, everything we discuss, it's for reference, for educational purposes only.
Absolutely, central point.
You, the listener, you must always prioritize and follow your specific local guidelines, your hospital protocols, and the clinical practice mandates right there in your own operating room.
Yeah, that distinction is crucial. Always follow local guidance. Now, let's talk stakes, because the complication we're trying to head off here, it's serious.
It really is.
With laparoscopic cholecystectomy, the big shadow hanging over things is common bile duct injury, a CBD injury. We know the immediate issue is complex biliary reconstruction, often lengthy, difficult surgery. But the long-term picture, it's huge.
It's devastating. Increased patient morbidity, long recovery times.
And the cost, frankly. Major costs, both financial for the system and institutional impact. It's often called the most devastating complication in this type of surgery.
Hard to argue with that.
Okay, let's unpack this. Why did the risk of CBD injury actually go up when we shifted from open surgery to laparoscopic? It seems counterintuitive.
It does, but the data is pretty clear. The injury rates are significantly higher in lap cases compared to the open era.
So what happened?
Well, our source material points to a few key things. Number one is anatomical misidentification, just not seeing things correctly.
Right.
Then you got issues like inflammation, making the view difficult, surgeon inexperience playing a role sometimes, and, technical errors linked to not having a standard approach.
So it's not just about like a slip of the hand. It's fundamentally about misinterpreting what you're seeing on the screen.
That's the core of it, yes. Most injuries happen because the surgeon looks at Calot's triangle and mistakes the common bile duct for the cystic duct. They think they're clipping or cutting the cystic duct,
But it's the CDD.
Exactly. We're basically fighting against the visual challenges of laparoscopy itself. The 2D view, no sense of touch, and that risk of the tenting effect.
Tenting effect.
Yeah, where retraction can inadvertently pull the CBD up, making it look like it's running parallel to the cystic duct or even entering the gallbladder. It creates a visual trap.
Okay. If we connect this to the bigger picture then.
Yeah.
This is precisely why CVS is so important. It's not just another technique.
No, it's more like a cognitive safety net. It forces the surgeon to stop and prove the anatomy, methodically, before making any cut.
It standardizes that identification process to, eliminate the guesswork.
Exactly. It moves us beyond just, having a good feeling that you've got the right structure. You have to demonstrate it.
Which brings us right to defining the critical view of safety itself. Strasbourg, 1995, specifically designed to tackle this misidentification problem.
That's the one.
Achieving it is key. But let's break down the actual criteria. It's a three-part test, essentially. What's the very first thing you absolutely have to do?
Okay, criterion one, you have to clear Calot's triangle completely. Get rid of all the fat and fibrous tissue that might be obscuring things.
So total clarity.
Total clarity. You need full unobstructed exposure of what you believe are the cystic artery and the cystic duct. No hiding, no guessing.
Okay, clean stage. Makes sense. What's requirement number two?
Criterion two is about the gallbladder itself. You need to dissect the lower third of the gallbladder away from the liver bed.
Off the liver. Why that specific part?
It exposes what's called the cystic plate, and doing that helps with the final confirmation step.
Which is criterion three, the confirmation.
Exactly. Criterion three is the final check. The surgeon must be absolutely certain, visually certain, that only two structures are entering the gallbladder right at that point.
Only two.
Only two. What you've identified as the cystic duct and the cystic artery. And this has to be confirmed before you place a single clip or make any division.
Okay, here's where it gets really interesting, I think.
Yeah.
It's not just thinking you see it.
Yeah.
You have to prove it methodically. So what's the rule? The non-negotiable rule if the view isn't perfect or if even one of those three criteria isn't met.
The rule is strict. Unforgiving, really. If you fail to meet any one of those 3 criteria, you stop, period.
Stop cutting.
Stop planning to cut. You either have to dissect further very carefully to try and achieve the view,
Okay.
or you need to switch gears, use an alternative surgical approach maybe, or the ultimate safety step, convert to an open procedure. There's no sort of good enough view.
But isn't there, pressure in the OR, time
Right.
pressure, wanting to finish the lap case? What's the challenge for the surgeon when they realize, I can't get the CVS, I might need to convert?
That's a huge challenge. It's psychological partly. You have to fight confirmation bias, the desire to believe you see what you expect to see, and yeah, the efficiency mindset.
Right.
But converting isn't a failure. The data, the guidelines, they all say converting to open is actually a sign of good judgment. It shows you prioritize safety.
So accepting that delay, that change of plan to prevent a potentially catastrophic injury, that's the hurdle.
It is. And it's often the safest and honestly the bravest decision a surgeon can make in that moment.
Yeah, absolutely. Okay, let's walk through this step by step like we're in the OR. What are the actual actions needed to achieve that confirmed CVS? It starts before the first cut, right? With setup.
Absolutely. Setup is key. Optimal patient positioning makes a huge difference for visualization. Usually it's supine, a bit of reverse trundle limber.
Hand up.
Head up, yeah. Helps gravity pull the bowel down, out of the way. And a slight tilt to the left. That helps rotate the structures a bit.
Using gravity. Clever.
And of course, you start with the WHO safety checklist. That's just standard baseline for everything.
Okay, patient positioned checklist done.
Yeah.
Then we move to actually getting the exposure, the retraction. You mentioned stretching Calot's triangle.
That's step 2, and it's critical. You want to create space, separate the structures. The standard maneuver is grasping the fundus of the gallbladder,
It's the top part.
right, the top, and retracting it cephalid towards the patient's head and a bit towards their right shoulder.
Okay.
And at the same time, you grasp the infundibulum, the lower part near the duct, and retract that laterally out towards the patient's side, their flank.
And that specific push-pull, that vector, it stretches the triangle.
Exactly. It puts the cystic duct under gentle tension and ideally pulls it away from the plane where the common bile duct lies. Gives you a better angle.
Makes sense. So once you've got that tension right, then comes incision and clearing, steps 3 and 4.
Yep. You incise the peritoneum, the thin layer covering the area, usually along both sides of the gallbladder neck. That opens up the hepatocystic triangle, Calot's triangle.
And then the clearing, getting rid of that fibrofatty tissue. How do you do that safely? It sounds delicate.
It is. Step 4 is meticulous clearance. You use careful dissection, both blunt and sharp. Importantly, you want to avoid just blasting away with cautery.
Why is that?
Too much cautery can cause thermal injury to nearby structures, like the bile duct, or it can just char the tissue and actually make identification harder.
Oh.
And a really key landmark here, especially if there's some inflammation, is Rivier's sulcus. You need to find it if possible.
Rivier's sulcus. Remind us why that's so vital, especially if the view is maybe a bit obscured, that whiteout situation you sometimes get.
Yeah, Rivier's sulcus, it's like a little groove or cleft on the liver surface, usually just above the plane of the main bile duct and hepatic artery.
Okay.
Finding it helps you define the safe upper boundary for dissection. The rule, the mantra really, is stay superior to Rivier's sulcus. Stay above it.
Because below it lies.
Below it is generally where the common bile duct and hepatic artery are running, so staying above it keeps you in a safer plane, heading towards the gallbladder and cystic duct, away from the main highway, so to speak.
Got it. A critical landmark. So once we've cleared that space, staying superior, that takes us to step 5, which links back to criterion 2, separating the lower third of the gallbladder off the liver. Why that specific step again?
It's all about visual proof. By lifting that lower part of the gallbladder off the liver, off the cystic plate, you get a look behind it, essentially.
Okay.
You're confirming that the two structures you've isolated, the duct and the artery, actually do terminate right there into the gallbladder wall. You confirm they aren't just running alongside it, or that there isn't a third structure hiding back there.
Like an aberrant gustle or something?
Exactly. Or worse, the CBD itself tented up. This step helps ensure you're seeing the true termination point.
Okay, that makes perfect sense. Then comes the final step before the point of no return. Step 6, confirmation and the timeout.
Crucial. Before any clip goes on, before any structure is divided, you must take a formal pause, a timeout.
Like the WHO checklist pause.
Similar idea, but specifically for CVS confirmation. You stop. You actively review the visual field, ideally with the assistant or the whole team, confirming again. Do we clearly see only two structures entering the gallbladder? Have we met all 3 CVS criteria?
And you document it.
Yes, documenting that you achieved CVS and performed this check is vital. And if, even after this deliberate pause, there's any doubt, any uncertainty about the anatomy, you abort the division. You don't proceed.
That's the discipline right there. Now let's shift to the tough cases. The situation nobody really wants, but surgeons have to manage, difficult anatomy. What are those danger signs that flash red, telling a surgeon, uh-oh, CVS might be really hard or impossible here?
Yeah, the classic danger signs are things like severe acute inflammation, cholecystitis, where everything is swollen, maybe stuck together.
Right, the tissues are angry.
Exactly. Or dense adhesions from previous surgery, maybe scarring, sometimes congenital aberrant anatomy where the ducts or vessels aren't where you expect them. These are all red flags. Progress has to be incredibly cautious.
So if you hit that wall, despite best efforts, careful dissection, you just cannot safely achieve that clear 3 criteria critical view of safety. What are the options then, according to the sources?
Safety first. The sources strongly recommend shifting to alternative techniques rather than pushing through uncertainty. One option is the fundus first technique.
Starting from the top down.
Right. Dissecting the gallbladder from the top, the fundus downwards, staying on the gallbladder wall, moving away from the critical triangle area until the very end.
Okay, what else?
Another key one is subtotal cholecystectomy. This is really important in bad inflammation. You basically remove most of przedni ścinaj leczniku, but you leave a small part of the back wall attached to the liver, deliberately staying away from the ductal structures. You oversew the remnant or fulgurate the mucosa.
So you don't fully remove the gallbladder, but you remove the stones and the inflamed part.
Precisely. It resolves the patient's acute problems safely without risking a CBD injury in a hostile field. There's also the posterior infundibular technique mentioned sometimes. These are all valid safety maneuvers.
But if even those alternatives don't seem safe or don't resolve the uncertainty around the ducts, that non-negotiable rule kicks back in. If unsure, don't cut. What's the absolute final action plan?
The guidelines, the sources, they're crystal clear on this. If CVS cannot be obtained and alternative techniques aren't suitable or still leave doubt, the surgeon must not clip or divide the main structures identified.
So what do?
Plan A is often to get help. Call a senior colleague into the room for a second opinion, fresh eyes. Plan B is conversion to open surgery. Get your hands in there, get better exposure, tactile feedback.
And plan C?
Plan C could be using intraoperative cholangiography, IOC. Shoot some dye into what you think is the cystic duct and get an X-ray picture right there on the table.
Let's talk about IOC for a second. It's not just for when you're lost, is it? Some argue for using it more routinely.
Well, it definitely clarifies the anatomy. It gives you a roadmap of the biliary tree. And yes, there's data suggesting that in complex cases, or even routinely in some centers, using IOC is associated with lower rates of CBD injury overall.
What's the trade-off? Time, radiation.
Yeah, it adds a bit of time to the procedure, maybe 10-15 minutes for setup and the imaging. And there's a small dose of radiation, but you weigh that against the time, the cost, the morbidity, the sheer disaster of dealing with a major bile duct injury discovered after the operation. In difficult cases, most would argue the benefit of IOC clarity far outweighs those minor drawbacks. It confirms, is this structure really the cystic duct? Is it isolated from the CBD?
Okay, that makes sense. And we have to touch on documentation again. Why is getting that proof, a photo, a video clip showing the achieved CDS into the operative node, so critical now?
It serves 2 really important functions. First, it's about quality improvement. It demonstrates that a standard safe technique was followed. Teams can review these images, learn from them.
And the second?
The second is, unfortunately, medical legal. Biliary injuries often trigger significant scrutiny, reviews, sometimes litigation. They're often seen as preventable never events.
Right.
Having objective, time-stamped photographic or video evidence in the operative note showing that the critical view of safety was achieved before division provides crucial documentation of adherence to the standard of care. It protects the patient record's integrity and, frankly, the surgeon.
Demonstrates methodical practice.
Yeah.
And this isn't just academic theory. The major professional bodies are behind this, aren't they? European guidelines, like from the EAS, the RCS.
Absolutely. They aren't just suggesting CVS. They essentially mandate its use, or at least striving for it. They emphasize documenting it using those timeout pauses.
And they explicitly address the difficult case scenario.
Yes, very explicitly. They recommend converting to open surgery as the preferred, safer action over risking a biliary injury if the anatomy remains unclear or CVS can't be confidently achieved. The priority shifts completely from must complete laparoscopically to must ensure patient safety above all.
Which brings us right back to the start. The critical view of safety, when applied rigorously, seems to be the single most effective strategy we have to prevent common bile duct injury during laparoscopic cholecystectomy.
It demands caution, clarity, a methodical approach, and that willingness to change the plan when needed.
So it's not just about manual skill, is it?
No, not at all. And maybe this is the final thought to leave people with. Technical skill is vital, obviously, but team awareness is just as important. Ongoing education, understanding the risks, creating a culture where anyone in the room feels safe to speak up if something doesn't look right.
Empowering the team.
Yes. And the readiness, the lack of ego involved in converting to open or calling for senior help when you hit trouble, those factors are arguably just as crucial as how well you handle the instruments when it comes to actually safeguarding the patient and, ultimately, the surgeon's own practice.
So what does this all mean? It means clarity in that hepatocystic triangle and Calot's triangle is absolutely non-negotiable. Thank you for joining us for this deep dive into surgical standardization.
And if you found this deep dive useful, please do not forget to share it with at least one of your colleagues or friends and help spread the word.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.